Assalamu alaikum. The non-clinical consultation day. First scenario, Julia Adam, 50 years old. Lady presented with body weakness. Please take history, examine her, and address the concerns. Here you go.
Hello, I am Dr. Muhammad. I am one of the doctor here in clinic today. Can I confirm Ms. Julia Adam, 50-year-old with me?
Yes.
Okay, Ms. Julia, we are here today to discuss some health issue for you. I will take some history and examine you and write some notes. All will be confidential if you don't mind, okay?
Okay.
Can you tell me, Ms. Julia, in your word, what brought you today to the clinic?
Yes, I have been feeling some weakness in my body and it has been getting worse, so that is why I'm here.
Okay, Ms. Julia, sorry for this. Since when started this?
Started about, I mean, you can say it is gradually getting worse, but mainly in the last 3-4 weeks.
Okay. Can you tell me exactly by weakness? Is specific in your lower leg, in your muscle, in your leg, or all over the body, or
Yeah, it's almost everywhere. I feel very
okay.
weak and yeah.
From the beginning, it started all over the body, or started a specific area of the body?
Yeah, it's all over the body mainly.
Before these 3 weeks, you will okay?
Yes, I was okay.
Okay. What about your joints?
Joint.
Yes. Any problem in the joints?
No joint pain. No.
Any muscle pain or tenderness?
Uh, I had some muscle pain, but that's something which has gone better.
Okay. When you stand from sit, you can do it, or it's difficult for you?
It's difficult for me, doctor.
So it's increasing by time, right?
Yes, it is getting worse with time.
Okay. What about your hand? You can use the keys or combing your hair, or the same also there is weakness.
I find it difficult to change my clothes, and I also find it difficult to comb my hairs, but I can button and unbutton my shirts.
Okay. Uh, any headache?
Yes, I do get some headache as well.
It started when this headache?
It's also for the last few weeks.
Okay. Which side of the head is there?
I mean, it's almost everywhere.
Okay. This first time also last 3 weeks.
Yeah, 3-4 weeks. Yeah,
Okay. Can you score this headache from 0 to 10? How much is severity?
you can say around 4-5.
Okay. You need any painkiller now?
No,
Okay. Does it go anywhere in the head, on the neck, anywhere? The pain?
no,
Okay. Specific time of the day there is this headache in the morning?
no,
Anything incredible like coughing or sneezing?
no,
Any vision problem?
no,
Okay. Any altered sensation in your body, numbness or tingling anywhere in the body?
no,
Okay. Any problem in the speech or swallowing?
no,
Okay. You notice any facial asymmetry in the when you look in the mirror?
no.
Okay. You feel any change in your weight?
Yes, I mean, I think that I feel that I might have lost some weight.
How much?
I'm
Total
not
load?
sure exactly, but I feel that I might have lost some.
Okay. What about your appetite?
My appetite has also gone down a bit.
Okay. Any problem in the swallowing?
No,
Okay. Any increase in your body temperature?
no,
Okay. Any sweating at night?
no.
Okay. Uh, uh, What about any past medical history of note I need to know? Diabetes, hypertension, anything?
Yes, I have. I mean, about 3, 4 months ago, I was diagnosed with some muscle problem, and after that, I was started on some treatment which I have been taking. Yeah, so there was some issue with my muscles.
Can I know your medication list, please?
Yeah, so I am taking currently this medication called prednisolone, and then there's another one which is called methotrexate.
Okay. Any change in the doses since this time?
I mean, I was started on a relatively high dose, and I have been trying to cut down on my dose at the moment because my doctor has told me to cut it down now. So, and I have seen that when I'm trying to do that, I'm not able to do that, and it seems that this weakness have not turned back again.
You feel better when you started this medication in the higher
I
dose?
I felt better for a month or so, but after that, I think that it seems that the things have been getting worse. But the difference is initially when it started, I had some pain in the muscles, and but currently I don't have any pain, so it's more kind of a weakness which is bothering me more.
Okay. I asked before any joint pain. You told me no. Any joint pain?
No,
Any deformities in your hand or
no.
any rashes anywhere in the body?
Yes, I have. I will show you the rashes. Go ahead with that. I'll share. Dr. Basim, please.
Yeah, sure, I will share.
Okay, go ahead.
Okay. Where is the site of the rash exactly?
Yeah, this is basically on my hand, also has some on the face, and also,
Started
uh,
also before this weakness in your hand, in your
sorry,
body.
sorry.
Started before your weakness in your arm, in your body.
Yes, yes, I think that this rash was there when I was started on that prednisolone. So it was also there when, I mean, along when initially the problem started, this rash was here.
You feel any back pain?
Back pain, no.
Okay. Any family history of note I need to know?
Yes, my my father and mother both have diabetes and hypertension.
They are okay.
Yeah, they are okay. And the other
Any
thing
allergy?
yeah, the one thing I just wanted to tell you is that uh, I have some family history of cancers as well, and some of the relatives.
Which type of cancer?
I mean, few of them they have thyroid cancer, and the others they have bowel cancer as well.
Okay, sorry for them. Okay, any allergies?
No,
Any travel history soon?
no,
Any sorry for this question. Any blood transfusion or any uh, blood drugs?
no.
You have partner?
Yes, I am married.
Okay. What about your period?
I have reached menopause.
Okay. Any birth pill or any hormone replacement you are taking?
No,
Okay. Any previous history problem in any pregnancies?
no,
Okay. Any sorry for this question. Any piercing, tattooing, or sharing needles?
no,
Okay. Any smoking?
no.
Okay. Any alcohol intake?
Very few. I mean, less than, you can say, 4 to 6 units a week.
Okay. What about, I will ask some question. You can answer me by positive or negative. Any coughing?
No,
Any short breath?
no, no,
Any heart racing?
no,
Any chest pain?
no.
Any tummy pain?
Yes, I do have some tummy pain.
Which side there is this pain?
It's lower down in my tummy.
How much score you can tell me from 0 to 10?
I mean, it's variable. It can vary from 5 to 6 at time.
If you need any painkiller, I can offer you now. Okay.
No, no, I'm fine, thank you.
Any what's you can tell me this pain? It is colicky. It is sharping pain.
No, it's kind of a dull and dragging kind of a pain.
Refer go to anywhere in the body. The part
Sorry?
going to
No,
any side.
no, no, no,
Okay. Any change in your bowel, in your bowel work, changing become loose or any bloody or any black stool?
no.
Anyone notice you are more pale nowadays?
Yes,
Anyone tell you that there is yellow discoloration to your eye?
no,
So your bowel work is okay. No loose motion or hard motion or bleeding, right?
no.
Okay. What about your water work?
I've noticed that the frequency of my waterworks has increased.
How increasing amount and frequency?
I think that it's more of amount and frequency both.
Any gravels there, so salty, any bubbles?
No,
Okay. Any dark discoloration or bloody?
no. But I feel more thirsty because of this.
Okay. Did you check your blood glucose?
No, I haven't checked that.
Okay. I asked it before about your vision. Any problem bumping to side, anything?
No.
Okay. Can I examine now, please?
Yes.
Okay. I will see the rash. I will look at it. Any oozing, any itching there?
No, the rash we have already shown it to you in the picture. And Dr. Basim, if you can share the picture of the face as well. Thank you. Okay, go ahead.
Okay. What about blood pressure and pulse? How much?
Yes. Yeah. Pulse is 90 beats per minute and the blood pressure is 160 over 100.
Any postural drop?
No postural drop.
I will check for muscle tenderness, any muscle pain.
No, there is no muscle tenderness.
Okay, I will check for proximal weakness. I will ask here to
Yeah.
I, abduction. There is.
Yeah, there is evidence of proximal muscle weakness.
Okay, on the face, pallor or jaundice.
She looks pale.
Okay, any mouth sore,
No.
any sign of dehydration, skin trigger, woody tongue,
No. No.
lymph node, anterior cervical, posterior cervical.
No.
I will ask her to swallow some water. Any swelling in front of the neck.
No.
Okay, I will check for the tummy, superficial palpation, deep palpation, any swelling.
Yes, there is some tenderness in the lower abdomen.
Okay, any hepatomegaly, splenomegaly.
No hepatomegaly or no splenomegaly.
Okay, I will check chest rapidly in the basal upper zone. Any crackles there?
No crackles in the chest.
In the
Totally
heart,
not select.
S1, S2, any gallop, any sign of failure?
No.
Okay, lower limb, anything there in the lower limb, rashes, anything? Otherwise, the
It
other
seems
rashes.
they bilaterally they looks little bit puffy.
Okay. Thank you. Uh, can I ask Ms. Julia, what's your concern?
Yes, doctor, I just wanted to ask you that, I mean, why I'm getting all these symptoms again? Is it due to my muscle problem again that I have been suffering from these problems?
I appreciate your concern, Ms. Julia. After taking this examination, have some possibility of some sorry to tell you, these rashes in your body called dermatomyositis, and this don't bother yourself by this name. It is an immune problem attacking the skin, but it is related to some possibility of cancer there.
So I have a cancer, doctor.
There is a possibility of this because usually this cancer, this rash is coming with it. So we need to do, we admit you and do some, at least for 1 day, to do some imaging and labbing to rule out any hidden cancer there. Especially you have a family history of cancer. Can I
Okay.
tell you, can I ask you, Ms. Julia, any weather preferences you have?
No. So I sure I have a cancer.
Not sure, Ms. Julia, but you have some alarm sign, losing of weight, losing of appetite, and these rashes. It give us some alert to do some imaging and lab and workup to rule out any cancers in the abdomen, in the tummy.
What? Okay, why I'm feeling weak? I mean, is it all a part of the cancer which you are saying?
No, but this problem in your this the rash, it is related to your muscle and your skin. This is the immune system mistakenly attacked this the muscles, so you feel this weakness.
Okay. Is it curable?
After doing our workup, if there is cancer and it is in this early stage and we can control it and manage and treat it, it will be reversible and curable. We hope this.
Okay, all right.
Any other concern?
No, that's it. Thank you.
Okay. Examine questions. You can start now the batch, yeah?
Yes, okay. So briefly present your case and give your differentials.
Yes, we have 50-year-old Miss Julia presented with a 3-week history of gradual onset and progressive course of muscle weakness with rashes. So, by examination, there is headache rope and button in the hand, step-like distribution of the rash, and this all along with dermatomyositis. And there is alarm sign of weight loss and loss of appetite from the history with family history.
Sorry, I can't hear you. Hello.
Yes.
Uh-huh.
Last thing you hear what?
So you were saying about the discoloration and all these things.
Yes. About with by examination, there is rash significant for person and good thrombobule in the hand and the cap-like rash on the chest, and all going with dermatomyositis on the background of family history of cancer thyroid and cancer, another cancer in the abdomen. There is proximal muscle weakness. There is a lower abdomen tender and I don't remember really there is a mass I felt or not. I don't remember. But the lower abdomen there is tender abdomen there on the left side of the abdomen. With
So what
also
is your diagnosis?
there
What
is
is your diagnosis? Sorry?
there is uh, polyuria and polydipsia there.
Mm-hmm. So what
So
is your diagnosis?
doing this, putting all this together, we have dermatomyositis with a hidden cancer colon or cancer, but no positive history in the GIT. There is cancer ovary and there is hidden cancer there in the abdomen.
Okay. And what do you think is the cause of her current weakness?
She has dermatomyositis, and dermatomyositis causing weakness.
All right, okay. Any other differential?
We need also other differential of men type 1, but against that, in no change in the facial appearance, no vision. only there is polyuria going with hypercalcemia, but no other features. And there is tummy pain, also going with hypercalcemia. So mean one, but not a complete criteria. Hello?
Okay. Uh, can this lady have a iatrogenic Cushing syndrome?
Cushing syndrome.
Iatrogenic Cushing syndrome.
I asked about the weight. I didn't see all features.
Mm-hmm.
You will see the picture again. Sorry. Oh, I didn't see the face. Okay. Yes, I see the face now. After 3 weeks of taking high dose of steroid, also there is one possibility of having there is a cushinate feature there with proximal muscle weakness, and there is I should examine more about the fat distribution in between the scapula, back, and the face. Yes, this is a possibility also iatrogenic Cushing syndrome.
Right. Any other cause of Cushing in this patient you can think of?
Other cause of Cushing?
Yes.
Secondary to malignancy, paraneoplastic.
All right. So how you are going to investigate her?
Firstly, apart from the basic lab, CBC for anemia because she is pallor, and PSA-CRP for activity of the inflammatory disease and connective tissue disease. Also liver and kidney function for any affection. I will send for her serum 24-hour cortisol level screening, salivary also cortisol level midnight. I will send auto antibodies, ANA and ANCA and anti. I forget the heliotrope and the dermatomyositis antibodies.
Sorry, your voice get it disconnected in between. So which antibodies?
Auto antibodies. I will send ANA and ANCA and smooth and anti-Roantla. Really, I forgot the dermatomyositis antibodies. I will send the CK level, CBK level. I will send also. I will do imaging, ban CT abdomen, CT chest, screen and BET scan, screen for any malignancy. I will send the muscle biopsy and
Okay. Any other investigation?
cardiac tumor marker, cancer 19-9 and 125, and cancer CAA, cancer also CAA, tumor marker. Okay.
How you are going to manage this lady?
Will disciplinary team, including the urology and oncology, also the doctor. According to
Sorry,
the
your voice is a little bit interrupted. I couldn't understand. So what exactly, how you are going to treat her?
by multidisciplinary approach, we will share our rheumatology and oncology and and OB-GYN also, and GIT doctor. So according to the finding of the imaging, if there is cancer there, we start to staging it by VET scan and CT cap to stage it and start the treatment. Regarding the rashes, we'll refer her to dermatology doctor to manage it by screens or cortisone ointment. Regarding the if confirmed the Cushing by rheumatology doctor to adjust titrate down the steroid and change to other DMARD. But the main treatment for the head and cancer there. Okay. Also, education and counseling and for the patient, sharing social and occupational health and how much affect her life and his job. And physiotherapy also until the muscle resolves it from the to be more resolved from the weakness.
Okay, right. So you mentioned one of your differential as men 1 or men 2. What are the components you have found in this patient?
There is criteria one sign of hypercalcemia. So there is parathyroid. And about the weight, you mentioned weight loss, so against and no facial appearance against pituitary. The tummy pain, but no criteria of pancreatic, no loose motion, no sign of malabsorption, no greedy oily stool. So also against the pituitary. I asked about any heart racing or any, you mentioned no, so against the pheochromocytoma. Really, I can't confirm which in there because the symptoms are not clear for me.
All right. Okay. Thank you. Right.
Okay. Thank you, Dr.
Hypercalcemia, paraneoplastic, the cause of this hypercalcemia.
All right. Okay. Thank you.
Okay.
All right.
You can comment now, Dr. Hisham.
All
The
I
skills
think,
in the chat box, you can
yes,
comment.
yes, I have seen that.
Okay.
Right. I think that overall you did very well. So I think that your thought process and your approach was quite good actually, and you are going in the right direction in terms of. So if I go skill by skill, starting from clinical communication, so I think in the history, I think that you did a lot of things and you asked about a lot of questions in detail, and which was appropriate, and you try to dig in the details in. But only thing I think in the history was about the time management because you started examination after the 11 minutes. I think it in the exam most likely you will be doing it early because you will have when you go and you will see the face of the patient, then you will be more direct and then you will go accordingly. So I think so. Otherwise, I mean, question wise, I think that you covered most of the things. Few of the questions we all need to remember whenever we come across a musculoskeletal case, always ask about these 5, 6 questions, which could be, uh, I mean, just as a routine. For example, anyone having a problem like musculoskeletal problem, always ask about Raynaud's phenomena, always ask about dry eye, dry mouth, always ask about any tightness of the skin, difficulty in swallowing, rash, so oral ulcers, hair loss. These are the common questions. I mean, any rheumatological case, you need to ask these 5, 6 questions just to make sure that it is just the single component and not a kind of a overlap syndrome or a mixed connective tissue disease. But otherwise, I think that you covered almost all of the things which were appropriate. Uh, I think that examination could have been more kind of a targeted because you need to in your differentials because initially only when I probe you said that it could be iatrogenic Cushing as well. But if you will not ask this, I think that you might be asked question related to your clinical judgment that how you will fit in the high blood pressure and the urinary symptoms into the case and with the picture I have showed to you as well. So you need to defend it in a way that and need to do a target examination to look for signs of Cushing as well. I understand you were relatively you were confused that the patient have no weight gain, rather weight loss. But sometime, as I said, that and you already told in your differential about a possibility of a malignancy. In those cases, you may not be able to find that classical signs of Cushing with weight gain and things like that. So that's why it was important that you should still consider keeping in mind that the patient has told that she has been on high dose of steroids for the last 3 4 months. So Cushing should always be kept in the differential irrespective of the weight changes. So this is one thing I think you could ask about, and you can target that as well just to fit in your differentials. Your clinical judgment was okay, but again, as I said that in this case, Cushing has to be, because the current presentation of the muscle pain, patient told you that when I started the treatment, uh, I started feeling better, and then after that, after some time, after say 2 months of taking the steroid, then I started getting the symptoms again. So there could be two possibilities. One is the relapse of the primary problem, which was dermatomyositis, and the other possibility could be a steroid induced. So you cannot, unless you do investigation, you cannot confirm that whether it is dermatomyositis or is it related to the steroid, and the patient have developed an iatrogenic Cushing. So this is another thing you need to be mindful, obviously, because when you will be appearing. So concerns, I think you dealt the concerns very well. So I think that definitely it was satisfactory. Differential, I would put you in a borderline position only because the current presentation you didn't mention the Cushing. Even I probe and you still argued that the patient had no weight gain. So I told you the reason for not gaining weight was as you already mentioned in your differential, as the possibility of dermato with underlying malignancy as well. So that is why you still need to obviously, when you will miss this differential, so you most likely will be getting borderline in the clinical judgment as well. But the rest of the skills, I think that they were all fair. The one thing I just want to mention is that, or maybe I can ask you, how will you differentiate muscle pain or muscle weakness uh, from dermatomyositis, or is it due to the myopathy of Cushing? How you will differentiate?
I think from Cushing, no muscle tenderness, but with dermato, there is muscle tenderness.
Very good. So this is one. And biochemically, how will you differentiate that?
Dermatomyositis, I think there is high CK level. Cushing, I
Yes.
think moderate or
Yeah.
low.
So the enzyme level will be normal because it is myopathy, not myositis. So steroid-induced myopathy, and in myositis, because it is inflammation, so the muscle enzyme like CK and aldolase level, they will be high. I think that I don't know that uh, whether it was okay to put a differential diagnosis of multiple endocrine neoplasia in this patient, because he hasn't had any symptoms to suggest uh, any component of the multiple endocrine neoplasia. So I don't think that so I think that's something I don't feel that was an appropriate thing to put in as a differential, considering the patient have no symptoms to suggest that. And yeah, so the other thing by which you can explain all these symptoms, as you have pointed out, the patient might have an intra-abdominal malignancy. And the patient, so initial presentation 4 months ago was with dermatomyositis, and this pain now, which is in the lower tummy. So there could be a possibility that the patient have, as you already pointed out, that the patient have an ovarian cancer or even a adrenal cancer, and there's a possibility that there may be an excessive secretion, ACTH secreting cancer as well. So that's something which could explain all the things which have been happening. Yeah, so overall, I think that you did very well, because Cushing syndrome is quite common. So I just wanted to make a little bit complex so that we cover all the areas and the association just in case if, but most of the time in the exam you will find a Cushing syndrome either as a direct adrenal tumor, most likely as a Cushing syndrome, or you might find it as a component of a Cushing disease due to a pituitary adenoma, a secretion of ACTH from them. Or the third possibility, which you might get in the exam, which is actually more common, is in patients taking steroids for some other indication. And last but not the least, it could just be due to ACTH secreting tumors, which could either be tumor of the lung, tumor of the ovaries, tumor of the breast. So these are the four things. I don't hear you saying anything about, uh, I I mean, uh, I don't know whether you, because your connection was not very good, so I don't know whether you have mentioned anything about the dexamethasone suppression test or anything like that, because I couldn't hear about that. So if you have mentioned, I think that's something obviously that's a part of the investigation as well.
First screening, cortisone
Yeah,
24 salivary midnight screening.
yeah, yeah.
To
So
differentiate
if the
between
screening is
cortisone
positive, yes, if the
and
screening is positive, then the next step would be to do for the low dose dexamethasone suppression test. Yeah, yeah. So otherwise, I think that you address all the concerns very well, and I think the approach was very good. So yeah, well done. That's it from my side.
Okay, thank you, Dr. Hisham. My comment regarding the differential. I think here the polydipsia and polyuria, it's related to the high blood sugar because of steroid, right?
Yes, yes.
So it's not hypercalcemia, Dr. Muhammad, as you mentioned, men, one of the differential. Even you don't have other manifestation of men. No
yes, okay.
pituitary.
But I mention it because it was I asked about any blood sugar mention and tested before. So I know there is, and when I put the differential, I put against that all the criteria not there. So, but he asked about another differential, and there is lag on the picture. I didn't see the face at all. I see the rashes at the beginning, and then I didn't see the face. So not coming in my mind at all.
It's okay. I want to clarify it. So men cannot be as differential in this scenario. Let's go back to the other differential to repeat them, Dr. Hisham, for other candidates. So in the top of differential, I will put Cushingnoid or Cushing syndrome because of the extra or exogenous use of steroid, right?
Yeah.
The
Sorry,
second one,
Dr. Basim, I
yeah.
think that sorry, you can continue, but I think that you shared the communication scenario, which we did yesterday. So if you can share the,
Really?
uh, yeah, yeah. So for my scenario,
I'm so
you need
sorry.
to, yeah, no, okay, thank you. You carry
Yeah,
on.
I will share yours. Yes, sorry. Okay, continue your differential, Dr. Hisham.
No, no,
Dermatomyositis?
yes,
Dermatomyositis?
yes, yes. So I think that in this case, first of all, we need to find out the patient presentation is with the weakness. So weakness and examination revealed proximal muscle weakness as well. And in the history, the patient told that uh, he was having some muscle problem and started on azathioprine and methotrexate and also some steroids, high dose steroid. So, and the patient told that initially 1 to 2 months she was getting better and then started having this weakness. So if we pick it like this, then we can think logically. So it's a dermatomyositis which was getting better, and due to the high dose steroid, because the patient was unable to wean off, and the reason not being able to wean off maybe because the dermatomyositis due to underlying malignancy generally it does not respond very well to the steroid treatment. It responds to the treatment of to the cancer. So maybe that could be a reason that patient was unable to wean off the steroid and now started developing feature of Cushing. So I think that if the examiner asks you what is the cause of the weakness in this patient, so I would put rather iatrogenic because there was no muscle tenderness at the moment, and I would put it as, and there were other feature like hypertension, there are feature of hyperglycemia. So I would put a possibility of an iatrogenic Cushing syndrome first, and then other thing, dermatomyositis with difficult to control symptom, and then there's an underlying
Cancer.
malignancy which could be
Yeah.
associated. So I think these are the things which I think would be
Yes.
more logical.
Perfect. Yes, this is the differential. Three differential is enough, and all of them make sense. Thank you, Dr. Hacham. The other skills I want to comment on here, the history taking. Again, I don't think if you went organized, Dr. Muhammad, because you asked lastly about the systemic review. However, the steroid as a medication, sometime the candidate or the surrogate will tell you as a separate medication. If you ask about show me your medication list, or if you ask particularly about the steroid, he will tell you. Otherwise, he might tell you, I don't take anything else. So please be sure that you ask about any steroid by name, or at the end, tell him, please show me your medication list. Supposed to be written there.
Yes, and Dr. Basim, one more thing regarding if you clinically suspecting Cushing and there is no steroid history, then always ask about any herbal medication over the counter or something like a quacks being, because a lot of time these people they do give steroids to relieve the pain or symptoms. So I think it's not always a prescription medication. You might find evidence, especially if you have a striking finding of Cushing on the examination and then the patient is not giving you history of steroid. So in that case you can ask, and it is important to ask about these question about the medication from other sources, like over
Yes.
the herbal medications or medication from like in sometimes the Hakimi medication and stuff like that.
Mhm.
I think these are important to ask when you are thinking about iatrogenic Cushing as well.
Perfect. The other thing which was good, Dr. Muhammad asked about any allergy and any surgery, any past medical or admission, all these things will help you if there is something hidden. Let's go to the other examination finding. Here you can have also striae at the abdomen. You might have also easy bruising or some ecchymosis in the hand or forearm or other areas. So be sure that you examine these things, plus the fat distribution, as you mentioned, at the face or interscapular. Okay, Dr. Muhammad. This is what I want to add only to your examination steps. The clinical judgment, yes, I agree. You mentioned the investigation of choice. And what about the imaging, Dr. Muhammad? You mentioned if you suspect
Yes,
Cushing.
Dr. Bassem, I mentioned CT cap and a BT scan for any screen for cancer and the tumor markers also.
Okay, if you suspect Cushing disease, what you should do?
You mean MRI brain?
Yes, MRI pituitary. Okay, MRI pituitary. Of course, after doing the investigation, the steps of dexamethasone, high dose and low dose. For the exogenous, you did the CT or CT cap, chest, abdomen, and pelvis, which is appropriate, and CT adrenal if you suspect Cushing syndrome. Clear? Okay, let's talk about the medication, pharmacological option in this scenario, how to treat the Cushingnoid or Cushing syndrome. Particularly in our scenario today, how you treat the Cushing, exogenous Cushing.
I mentioned it will be by the rheumatology doctor. He will treat down uh,
Perfect.
the steroid and replaced by another DMARD.
Okay, can we stop the steroid?
Not suddenly. I told you he can't treat it.
Okay. Yeah, perfect. So I'm trying to revise the questions to be only beneficial for all and also to sum up. Okay. As you said, so you cannot stop the steroid abruptly. You have to find out another option before stopping the steroid. What if you have Cushing syndrome? What are the pharmacological options, you know?
Cushing syndrome, you will treat the cause itself. If malignancy, should be treat the source. If from adrenal by surgery, right?
Okay. Yes, before surgery. Any pharmacological option?
Yes, I think there is something called metarapone, and also
Yes.
ketoconazole also can be given.
Yes.
I think these are the medications which can be
Yeah.
used for pushing.
Yeah, perfect. So metyrapone or ketoconazole can be used to treat Cushing syndrome. For the definite surgery or definite management or treatment will be surgery, as you said, adrenalectomy. What about the Cushing syndrome? Sorry, Cushing disease, Dr. Muhammad.
So surgical,
Yes.
whatever, macroadenoma, and
Hypophysiectomy. Exactly. Yes. So you remove the pituitary gland or the adenoma itself by neurosurgical intervention or whatever. But don't forget to mention multidisciplinary team approach, including the surgeon, because the surgeon might be involved in all these, even with the exogenous as cancer, for example, the chest or the GI. Also, the option, the surgeon will be in the team. Clear? Okay, Dr. Hisham, I will read for you your scenario quickly. Doctor, you are the doctor in the medical admission unit, Mr. Bendit. Bendict, 50 years old. He has leg weakness for the past 2 weeks. Blood pressure normal, blood heart pulse rate is normal, temperature 37, saturation 99. Examine patient, take history, and address the concern. I ask for, thank you, Dr. Riham. She mentioned the anti-MI2 for dermatomyositis, anti-Jo1 for polymyositis. And this is for you, Dr. Muhammad, because I know you know it, but with the mental block, you will forget everything. But please, with the repetition, you will remember. Okay?
Okay, please, Dr.
Yes.
Yes, there are two more. If you want to add into anti-Jo1 and anti-MI2, there are two more. One is the anti-SRP, the signal recognition peptide antibody, and the fourth one is anti-MAD5. I think this MAD5 is the one which is generally associated with the underlying cancer as well. But anyone can be, but generally most commonly. So these four antibodies: anti-Jo1, anti-MI2, anti-SRP, anti-MAD5. So I think these are the four which are
Yes,
which are
right,
common.
Dr.
Yeah.
Hisham, but remember the important two first, then you can add what you
I
mentioned.
forgot the most common, yeah, Dr. Hacham. You are
Yes,
adding
exactly.
Yeah.
but
So more
don't
common is
forget
if you, I mean, if you need to remember two, so just remember anti-Jo1 for
Yes.
polymyositis and
being
anti-MI2
texting
for.
at the exam. Be sure it will be difficult. Don't be
Yeah,
texting.
yeah,
Okay?
yeah. It will be. I.
Yeah, yeah. So remember the most common and
Yes.
try after that to mention the others.
Yeah, the morning he is calibrating some words only. He need to hear some words only from you.
Yeah.
Yeah, yeah.
Okay. Any question from anyone before moving to the next scenario?
I just have one question. I'm sorry, one comment. So you did very well, actually. Your history taking, your clinical judgment. I think most of the um, you just did most of the important thing. I just would like to add one thing. If you can just screen more for the underlying pathology or underlying malignancy, because the patient mentioned that he's been having tummy pain. So this could be ovarian cancer. So if you can just ask more about if the patient have to explore about the cause of the underlying malignancy, if the patient has any bloating, any abdominal distension, or any these are the things, and also ascites in the examination is very
I think that,
important.
I agree that, because I think I wanted to make that point that you need to ask about abdominal distension, which you didn't ask, and you need to ask and examine for the ascites. I think that I made that comment, but I couldn't. Thank you very much. I think that was something very pertinent. Yeah.
So, the most associated malignancy with dermatomyositis is lung cancer, colorectal, ovarian, and I think pancreatic cancer. So if you can just like 1 to 2 question of all these, I think you've asked about the colorectal cancer, about the bowel habit. So if you can just add, because there is high suspicion that this patient might be having ovarian cancer. So 1 to 2 question more about the symptoms like bloating, distension, And also, you might add jaundice also, since the patient has abdominal pain. It's not typical for pancreatic cancer because it's lower abdominal pain, it's not epigastric. But also, you need to ask about one symptom of pancreatic cancer, like jaundice and ascites in the examination. I think the only like other comment that I will just give is to speed your history taking. You have all the information, I think, and you did history very well, but you took a very long time. So adjusting 7 to 8 minutes for the history taking, I think this should be the maximum. So more practice of speeding your talk. Thank you.
Yeah, thank you, Dr. Ahad. I would like to add to your comments or your words. Whenever you ask about tummy pain, ask about tummy discomfort. Sometimes the patient will feel the discomfort, not the pain. Suppose in this scenario, with distension or with something which is distended or some feeling of something inside my tummy, so he will not tell you I have tummy pain, and you might miss this complaint. So add your approach always. Whenever you ask about tummy pain, ask about tummy discomfort. Splenomegaly, the patient will feel discomfort, will not feel pain. Hepatomegaly as well. The ascites. All of these, the patient will tell you, I have discomfort. If you ask more, you will feel or you will have distension. So don't ask like only tummy pain because you might miss the most important, which is discomfort. Okay, put it in your approach, Dr. Muhammad. Any tummy pain or tummy distension or tummy discomfort. Okay?
Yeah, but I think Dr. Basim, I agree, but I think that what I feel is that Dr. Mohammed will be able to do that in the exam, because when you come inside and when you will look at the face of the patient and then you will look into the clinical presentation, I think then he will be more targeted. So I think that I don't feel that he will be having any trouble, because I have seen him practicing. So I think that he most likely, that's what I feel, that he will manage it in around 7 to 8, because it was, I mean, if we don't look into the face or the rash,
Yes,
and we
yes.
keep on,
Right.
because dermatomyositis could be associated with the lung malignancy, could be lymphoma. Then when you are doing all these and when you have already seen that this patient, so first you need, I mean, if you haven't seen the face of the patient, first you are going to find out that what's the problem, what the cause of the weakness. Then you need to look for the steroid thing, then you need to scan for the underlying malignancy. So it will be quite a lengthy job to do. So I
Yes.
think that in the exam, I don't think that he will be having much trouble, because if you
Mm.
see the face and if you pick up these rashes and things, then I'm pretty sure he will be more directed toward that, and he will not be going 11 minutes into the history.
Yes, not only that, Dr. Hisham, I guess the surrogate will be instructed by the examiner to be fast in his reply. So the time will be more shorter than the online one. Okay, so be sure that you can overcome this problem in the exam. The time, but please also manage your time. Don't say, yeah, the surrogate will help me. No, sometimes they have a lot of finding, so it will take time. How to shorten? Be targeted, and whenever you see the case or the patient, you can know what's the case about. You can have a look before doing the examination. You can tell him, Can I have a look?" Yes, then sit down again, continue your history, and finish the examination later on.
Yeah. Okay.
Okay. If you're ready, we can start.
Yes, yes, I'm ready.
Yes. Here you go.
Hello, hi. My name is Dr. Khizar. I'm one of the doctor here. May I confirm your name, please?
Yes, I am Mr. Benedict, 50-year-old.
All right, Mr. Benedict. I'm here to discuss with you about your health condition, and then I'll take a history and examine you. Is that okay with you?
Yes, beautiful.
Right. So, Mr. Benedict, I understand that you have been experiencing some weakness in your legs for the past 2 weeks. Is that right?
Yes, yes.
All right. Okay. I'll come back to that problem in detail and we'll discuss and analyze that. But before that, may I know that have you got any other past medical history of any medical problem?
Doctor, I am have diabetes since 10 years now.
All right. Okay. And apart from diabetes, any other medical problem?
No.
All right. And may I know that what medications you have been taking?
Yes, I am taking metformin and glycoside.
All right. Okay. All right. We'll discuss about that in more. So, if you can just give me a little bit more detail about your leg weakness. So, how does it started?
Yes, doctor, since 2 weeks started gradually, then increasing by time.
Hmm. And
Now I
it start right.
can
And it started with both of your legs, or it was initially in one and then it involved the other?
no together.
All right. And have it started in your feet and then you feel that it is moving upward, or it involves all the legs at the same time?
So it started by my feet, then gradually come up. Then now my hand started.
Uh-huh. So you're feeling weakness in the hands as well.
Yes,
All right. Okay, first we analyze the leg problem. So you said that it started with the feet and now it is getting up. So uh, how it is affecting your mobility?
yes, doctor. All my daily activity affected now. Even my work, I am taking too much sick leave.
Right, right. Have you been able to walk?
Yes, hardly. I stand hardly, walk hardly.
Uh-huh. And you said that you have been feeling some numbness and tingling as well. Is it also something for the last 2 weeks?
Yes, but it was I have before, but I think increased nowadays. My GP mentioned for me this before. Maybe my diabetes is the cause.
Uh-huh. All right, right. And have you had any trauma to your back?
No
And have you noticed any pain in your legs?
pain.
Pain in the
No,
leg?
only the tingling only.
Right, right. And any pain in your back?
No,
All right, okay. And have you noticed uh, any accident with your waterworks?
my water work only when my glucose increased because sometimes I am not taking my medication. Really,
Uh-huh. So have you noticed that you have been incontinent?
no,
And have you been incontinent with your stools?
no.
All right, okay. And you said that now it has started affecting your arms as well.
Yes, my hand only.
Is it one hand or both hands?
No, both hands.
All right. And have you been noticing any pain in your hands?
This is doctor only tingling numbness.
Mm-hmm. Right, right. And the weakness also in both hands?
Yes.
And may I know that what are the things in your daily life which are affected by these weakness and the tingling you have?
Doctor, I mentioned for you, all my daily activity affected, even my work I can't go.
Uh-huh.
They will fire me.
Right. I'm sorry to hear about that. We'll sit and we'll definitely try to sort that out. Have you been able to uh, dress up yourself?
Hardly, doctor, hardly.
All right. Okay. Have you noticed pain anywhere in your body, like in the arms or legs or in your back?
No.
All right. Okay. Mr. Benedict, may I know that have you got any recent infection in the last 2, 3 weeks?
What do you mean, doctor, by infection?
I mean, if you have any kind of a sore throat or any problem with your waterworks or anything like loose stools or so, just want to.
Doctor, I have some flu, and I think after that I have some loose motion for few episodes.
And when was that?
Same time.
So it was 2 weeks ago.
Yes.
And after how many days of that episode of loose stool and flu, you started developing this weakness?
I have this episodes for 1 week, then started I feel weakness in my leg.
Right. Uh, do you still get those loose stools?
Oh, now better.
And your flu, you have mentioned that has settled as well?
Yes.
All right, okay. Little bit more questions about that. Have you noticed, I mean, kind of a yes and no question. Have you noticed any headache,
No.
any problem with your vision,
No.
any double vision?
Only my vision, some blurring. Also, my doctor told me from it's
All
new,
right.
new.
Any double vision,
No,
any headache?
No,
And any fits or scissor, jerky movement of your body?
no,
Right. Have you ever had a stroke?
no.
All right, okay. And have you had any uh, racing and pacing of your heart?
Yes, doctor, sometime I have this heart racing, especially nowadays.
Right, right. Have you noticed any difficulty breathing?
This heart racing, I feel not good.
Right. And any chest pain?
No,
Any cough?
no,
And any pain in your tummy?
no,
Any problem with your waterworks?
no,
Any rash?
no,
Joint pain or swelling?
no.
Right. And a few more questions. So, apart from that, have you got any family history of note?
Only my mother have diabetes also.
All right. And how, obviously, you have told me that you have diabetes. So, how is the control of your diabetes?
I am not good patient, doctor. My 3 months hemoglobin is 9.5
Ah, I'm sorry to hear about that. And have you been on regular follow-up with your doctor?
all the time.
Hmm. And have you been taking the medication regularly?
And for you, doctor, sometime I am forgetting it.
Right, right, okay. And may I know, Mr. Benedict, what you do for living?
Doctor, I am engineer.
All right, okay. And do you smoke?
Little,
How many cigarettes a day?
3 or 4.
Right. And how this is, I mean, do you drink alcohol?
Also a little, doctor, especially in weekend.
All right, okay. So, I mean, smoking in any form obviously could be hazardous to your health. So I would advise you if you could stop smoking. Or if you want any help, we can do that as well, and we have support available.
Thank you, doctor.
Mr. Benedict, do you drive?
Yes.
All right. I think with the weakness you're having, I would advise you not to drive till we sort that problem. Is that okay with you?
Okay, doctor, thank you.
All right. Okay. Mr. Benedict, I would like to examine you at this point.
Yes.
All right. I would like to examine by looking at the patient, general appearance of the patient, and after that, I would like to examine and check the blood pressure. I would also like to check the standing and lying, look for any signs of postural hypotension, any.
Little affected.
Okay.
Around 15 millimercury.
Right. Okay. And also, I would like to see if there's any prominent. Have you got any weather preferences?
No,
All right. I would also like to screen for the thyroid swelling in this patient as well. Apart from that, I would like to look for any signs of pallor in this patient, and
no.
I would like to examine the eyes as well to look for any uh, changes of diabetic retinopathy.
You want endoscopy?
Yes, I would like to do the visual.
Bypass.
Yeah, okay. I would like to offer fundoscopy to look for any signs. And then after that, I would like to examine the legs of this patient. And in the legs, I would like to do a complete neurological examination, starting from the look of the whether there's any wasting or if there's any scar.
No scar.
I would like to check the tone, power, and reflexes.
Hypotonia. Will check for power. Proximal weakness more than distal. 4
Hmm.
over 5. 3 over 5. Then
Right.
what you want?
Reflexes.
Areflexia.
And also, even with reinforcement, there's areflexia.
Areflexia.
All right. I would also like to check the plantar in this patient.
Downgoing.
Downgoing. Okay. After that, I would like to check the sensations. Look for sensation in all the four, uh, like touch pain, temperature. So not temperature, vibration and sense of position and joint position and vibration.
Glove stock appearance. Position is intact.
Right. After that, I would like to ask the patient to stand. I will stand and I will be with the patient and first see if the patient has any problem with the balance or ataxia.
Bypass this.
Sorry.
He can't stand. No need.
All right. Okay. Then I would like to check the gait if the patient is able to walk.
He can't.
All right. Okay. After that, I would like to look into the back of the patient to see for any scars in the back, any
No
surgical
tender.
scars or any spinal tenderness.
No scar. No tenderness.
After that, I would like to examine the in the lower limb. I would also like to check for Romberg sign to look for any sensory ataxia.
No.
Then I would like to examine the upper limb of this patient, and the same sequence I will repeat along with tone power reflexes, sensations, coordination.
Only distally more weakness. Proximal is okay. Reflexes is hyporeflexia.
Right. And then after that, I would like to examine the patient eye. I would look like to check for the extraocular movement of this muscle.
You mean its shape?
Yes, I would like to do that.
No pain. No diplopia. No nystagmus.
Extraocular movements of the eyes.
What you mean? What you mean?
I
What you
would like
want?
to do the
Nerve.
H shape movements.
I told no diplopia, no pain, no gazing, no pulses.
All right, okay. Right. After that, I would like to examine the heart to look for any abnormal rhythm and also the heart sounds if there's
2 minutes left.
any added
One,
sound.
this one is to normal, no gallop, no adventitious sound,
All
no
right, then I
murmur.
would like to offer a oxygen saturation of this patient and examine the bases of the lungs as well and the chest
Base of the
expansion.
lung, no crackles, chest
Mm.
expansion, start little affected.
All right, okay.
Saturation 95 room air.
All right. Okay, thank you. Mr. Benedict, may I know that what exactly are your concerns?
Yes, doctor, what's happening with me? Is this a stroke?
I fully appreciate your concern, Mr. Benedict. So I can tell you that it doesn't look like a stroke. I think most likely you have a condition which is called Guillain-Barré syndrome. Uh, this is a kind of a thing which can happen in someone who has an infection. So sometimes it's kind of a disease which can happen few weeks after some infections, and I think that that's something which you have been experiencing. It affects your nerve cables, and due to that you start developing weakness, and I think that most likely you have that, and we need to investigate for that. Any other concern?
Yes, doctor. Is this weakness will be permanent for me? I'm afraid it will be permanent.
Yeah, I fully appreciate your concern. I mean, as I said that at the moment it's too premature to commit, but based on what I have examined and after taking your history, I think that if it is again Barry syndrome. So I think that something which generally respond very well to the treatment. So we need to make sure that we admit you, and we are going to admit you for that, and we do the urgent investigation and start you in the appropriate treatment. So we are very hopeful that this is something which is likely to get better. Any other concerns?
Doctor, I will be honest with you. I have one unsafe intimate relationship away because my wife is away from me. Is in relation for this because I feel this lose motion after 2 weeks of this intimate relationship.
Right, okay. I think that that's one of the possibility, because in that case, we definitely are concerned about a possibility of infection. So that could potentially be linked as well. Thank you for letting us know.
Hey, doctor, I am working as an engineer in a battery company. Any relation with this?
You're working in the factory, engineering factory?
Yes, in a
I'm not.
battery company.
Yeah, okay. I mean, it seems unlikely that it is related to your, because the problem has just appeared, and it seems quite kind of a sudden in the last couple of weeks. So I don't think that this is, and it's progressive, and especially with your history of recent infection. So I don't think it is something related to your occupation, but yeah, but seems unlikely.
Yeah, doctor, thank you. Please, doctor,
Alright.
don't tell my wife about this issue with me, okay?
Sorry.
Can you don't tell my wife about these issues, what I have told you?
Yes, I think that this is something obviously which will be the confidentiality will be maintained between you and us. So it is only when there are certain things which come up which could potentially harm some other people, then we need to sit and obviously still we'll encourage if anything comes like that for you to discuss and disclose it to your wife. But obviously, we are not at that point. So I think that we can discuss it further if anything comes up. Is that okay?
Okay, doctor, thank you.
You're
Yes.
welcome.
Examiner question, please now.
Yes, doctor, please tell me what's your positive finding?
Right, Onik. I mean, this 50 years old gentleman came in with a 2 weeks history of progressive weakness in the legs, which have been associated with some numbness and tingling, and now the weakness has affected the hands as well. In addition to that, he has a long-standing history of diabetes, which is poorly controlled. On examination, he has signs of lower motor neuron type of weakness in the lower limb. And apart from that, he is also developing some weakness in the upper limb as well, lower motor neuron type. He also has some symptoms to suggest some degree of autonomic disturbance in the form of racing and pacing of heart and a postural drop as well. And there are some visual symptoms, although on examination there wasn't any. So I think based on this history, and he gave me a recent history of infection 2 weeks ago, and at the end he volunteered to tell me about the sexual contact he was having. So I think all in all, I think that this patient has a post-infectious demyelinating polyneuropathy or a Guillain-Barré syndrome, and with other symptoms, I think that most likely he has a variant of the Guillain-Barré syndrome, which is called the Miller-Fisher syndrome.
Doctor, any other differential?
The other differential, in addition to that, because it is symptoms were quite classical for that, I think that it could be infectious uh, neuropathy. The other possibility could be, although the symptoms have only appeared 2 weeks ago, so CIDP or the chronic inflammatory demyelinating polyneuropathy seems relatively unlikely. Uh, Based on the onset. The other thing could be related to diabetes, the complication of the diabetes because of the uncontrolled diabetes, and that could cause multifocal neuropathies as well. So that could be one of the possibilities. He hasn't got any other symptoms to suggest any paraneoplastic kind of a syndrome. So I think these are my differentials.
Yes, doctor. What you will do for him? Investigation?
I think that I would like to start with the uh, initial investigation, including at the bedside. I would like to check the oxygen saturation of this patient and also like to check the force vital capacity. In addition to that, the routine investigation, including blood counts, inflammatory markers, urea and electrolyte, liver function, muscle enzymes, and I would also like to do uh, blood glucose level and HbA1c level. In order to confirm the diagnosis, I would like to request a nerve conduction study in this patient, and this patient might require a lumbar puncture to look for any uh, albuminocytological dissociation. In addition to that, considering that the patient have a recent high risk sexual exposure, so I would like to also send a STI screen as well and do all the screening tests, including the test for HIV, Hep B, Hep C, uh, and chlamydia and gonorrhea as well. Uh, so I think this, and also I would like to, if the patient have a dropping vital capacity and the oxygen saturation low, so I think this patient will also need a blood gases as well. So I think these will be my line of investigation.
What's your treatment?
Right. Okay. So once the diagnosis is established, and it's confirmed that this patient has a diagnosis of Guillain-Barré syndrome. So I think that the management of Guillain-Barré syndrome. So I would need to involve the multidisciplinary because this patient will need a proper monitoring because of the fact that the respiratory muscle can be affected at any time. So he will need admission into an ITU with under the care of a critical care team. Also, he will need monitoring for his blood pressure and for development of any arrhythmia. So he will need to be attached to a cardiac monitor as well. In terms of the treatment, uh, and also, I mean, he will require physiotherapy and occupational therapy as well. He need to stop smoking and stop driving as well. Regarding specific management, he will need IV immunoglobulins over a period of 5 days. And the alternate to that, if that's not available, then the second option could be plasma exchange, which could be done over multiple sessions. And during that, we can also monitor the response to, but the first line treatment is an IV immunoglobulin. So and as I said, that the patient might require respiratory support, and that is why this patient needs to be monitored and managed in the ITU.
Okay, doctor. Thank you.
You want to add any question else, Dr. Muhammad?
No, خلاص finish.
Okay. Yeah, perfect. So you can comment now.
Okay. You did very good, Dr. Hisham. But you cover the main diagnosis or the second main diagnosis. So, but the history, I think Dr. Basim may comment after me, but this time the history, you are very, very targeted on Guillain-Barré. It's clearly, and this is very, very risky. I think no high risk behavior, no travel history. You take it as a Guillain-Barré from the beginning, he has loose motion, then 2 weeks he has weakness. So, يعني this is my first comment. And you didn't mention, I think, any weight loss, any suspicion of any malignancy. Maybe Dr. Hisham, you can confirm on me, you mentioned or not. تمام? I think
I asked about weight changes and any weather preferences, if I'm not wrong.
no, I don't remember that there is.
No, it
asking
was
about
weather change only. You didn't ask about
weather
weight.
only, right?
Okay,
Yeah,
all right.
continue. Yes.
I think no temperature, no sweating, no weight loss, no travel history, uh, no high risk behavior. I think is the same. This first about the history. Even yes, you started very good on the lower limb weakness. You started to ask about which limb first, weakness or pain. But you didn't ask of lobby or stiff. It will help you to match this question. Very important in the approach. Then, yes, you ask about the alarm sign from the back pain, from loss of control. Despite this, during the examination, you didn't mention you need to see the anal tone or to check by yourself. يعني. You can offer because it's very risky, sudden and gradual weakness of the limb. Even he didn't mention back pain, even like this, it is must be rolled out, even by imaging also, by examination and by imaging. Again, about the history, yes, you asked about the back pain, any fall, any is very good this, but as a differential for any ascending paralysis, yes, Guillain-Barré after any loose motion, any infection, any flu, right? But there is around 3 or 4 another infectious paralysis. You told as infectious Guillain-Barré or infectious like this, but you should mention, يعني you can ask clearly for the patient. This patient, his life alone, his wife is away from him, he taking too much food from outside, he take canned food. So there is, you should mention, I need to rule out any botulism, any diphtheria, any rabies, any other viral infection, cytomegalo, Epstein-Barr. Even you didn't check the lymph node. Maybe this patient, the main is you need to treat the cause of this infectious. So and you he mentioned for you the HIV, and you didn't mention in your differential. Maybe the beginning of the seroconversion of the HIV, yeah, 2-3 weeks after or 1 month, he can be started even without rash. He has loose motion, diarrhea. يعني any diarrhea in any basis, TB, HIV, malignancy is very important. He mentioned also at the end for you, he has he working engineer in a battery. He is exposed to, you can ask him for any ascending paralysis, you are exposed to any chemical material like lead. This also can cause lead paralysis and lead numbness. He may be like this. So I think the problem from the beginning, your history very lacking. Examination, it's okay. You started, I don't know, you started by general, but I think he's clearly coming by lower limb. You should start by lower limb. Take your time until you see it, what's the type of the lesion, and يعني you will examine full lower limb from inspection, from tone, from muscle, from sensation. You will awake you will make the patient to walk, reflexes, coordination, all this. You will take at least 2 minutes, at least 2 minutes. So start in this case when the case is clearly, there is a complaint clearly for you. Start by the main complaint. Yes, you can go up for the respiratory affection, and you can rule out by your history. You feel your speech start to be the nasal to speech for you affected, breathing affected. Yes, you asked about vision also to rule out weakness. Then you will go up for the yes, to rule out it is upper motor, lower motor, but you examine it generally in extraocular ophthalmoplegia for Miller Fisher, right? But as a usual, you are putting stroke or anything, any upper motor neural differential, at least 7 nerve, as Dr. Basim mentioned before. You can check 7 nerve, it will differentiate for you upper or lower motor. Then extraocular ophthalmoplegia, yes, to confirm the Miller. Yes, and if you suspicion and put your differential in your mind, there is any botulism or any diphtheria or like this, it will help you from the, even by history, ask him any salivation, any dropping your eyelid, any voice hoarseness, any speech problem. All this will help you that there is some autonomic problem there is going, and thumb ascending infection is going, and is very risky. You can start your management by, I will, as you mentioned, I will check his breathing, his saturation, forced vital capacity, maybe need support from the beginning, and admit him to ICU because this is ascending paralysis, and I am afraid that the breathing will be affected. As you mentioned, you complete it. You mention it briefly, then complete at the end. Finish your acute management from the beginning. You will embrace the examiner. You will be very happy, and he will hear you very well about the other management, and he will forgive for any missing. Yeah. Because they are not forgetting any welfare يعني affecting the patient or any emergency. Okay. I mentioned you didn't check the lymph node, right? Yes, you didn't mention the lymph node is very important for any infectious, any malignancy. Okay. So our differential, sometimes they are putting acute intermittent porphyria in such causes. And you can ask about any bloody urine in morning, any tummy pain. Sometimes they are putting this in the differential, but you can rule out by history alone. يعني. So the differential, firstly, the most serious acute HIV seroconversion. then Guillain-Barré, acute demyelinating, right? Other infectious paralysis, including botulism, diphtheria, cytomegalo, Epstein-Barr, especially he has loose motions, okay, and heavy metal poisoning, lead poisoning, according his job. This is the 5 differential. You can mention HIV, GBS, infective paralysis. This is the most important differential. And you mentioned, I think, 2 of them. Thank you, Dr. Hisham. You did very good. And regarding the skills, Dr. Basim can grade you. Okay, Dr. Basim?
Yes, thank you, Dr. Muhammad. Yes, I am here. Thank you, Dr. Muhammad. Well done. Dr. Hisham, sorry, well done. Thank you for the case, Dr. Muhammad. I agree. I added in the chat box the missing parts in the history. So regarding the clinical communication, you might be minus because of the hypoglycemia. Always ask about hyper and hypo, Dr. Hisham. I always say this advice. It's not a matter of hyper only. Sometimes the hypoglycemia might be more harmful to the patient, right? So even you can address the driving from this part, not only the issue of vision due to the weakness. Here you can ask about the hypoglycemia and you can stop his driving if he has any of them, okay? Always remember to add this to your approach whenever you are analyzing a diabetes. The second thing, I like when you start to do the systemic review, but you ask about the stroke. What about mini stroke? What about heart attack? Okay, always remember this in gastropathy, the impotence. All this can be there in the case. Yes, it's not here in our case today, but it might be in your case in the exam. By the way, nowadays they are focusing on these things, the long disease or long-standing disease, hypertensive complication, diabetic complication, the association. So be sure that you are covering all these points while taking history. What I want to say as well for the diabetes, the hemoglobin A1C, you didn't ask about it, right? Or he said it. He said, right? I think he asked, yes. So it was high. Let's go to the weakness itself, as Dr. Muhammad mentioned, the magic question. I will try to make a magic question for every complaint. Today, the magic question of weakness, the type of weakness, is it floppy one or stiffy one? It's very important to know why. Here you can put the upper motor or the lower motor. So you can target and narrow your differential accordingly. So you will not go through the other question of upper motor, for example. But if you have the weakness of type, which is the stiffy one, you will go through the upper motor part or the upper motor causes like stroke or spinal cord. But anyway, you have to rule out the alarming sign. Dr. Hisham did it perfect. What are the alarming signs? Any back pain, any loss on the control of your water work, any pins and needles which was there, but it was related to the diabetic complication. The analysis of the complaint was perfect from Dr. Hisham, but he took time and he missed the part of constitutional. The constitutional is very important, believe me. The the HIV, you can add HIV as a differential, even from the constitutional. If he has weight loss, if he has loss of appetite, if he has night sweats or fever, you can definitely put the HIV as one or the cancer one of the differential, whatever the manifestation. So it can be any cancer can present with paraneoplastic. So you can say this is paraneoplastic related to a cancer. It might be the case, but not in our case today. So we can forgive it today, or we can forgive you about it. But in the exam, be sure that it might be in your differential, a cancer. You will be in trouble if this patient asks you, doctor, what I have, is it a cancer? It's a very problematic question. You didn't analyze any of these. How you can answer this question? Don't tell me no, I can, or it's yes, it can be one of them. How you can judge? So this part of the history taking, you can based on this part, you can answer yes or no. Okay, but here if you don't
put, or if you don't ask about these questions, it's difficult to say this is could be a cancer. Okay, this is my comment on the clinical communication. So I will give you borderline in the clinical communication. The physical examination, perfect, you examine everything, but you miss the lymph node. Whenever you have infection, be sure that you will at least, I would like to examine the lymph node if you don't have time. If you have time, go ahead. The abdomen as well, you can say, I want to examine the abdomen, the tone of the anal, and be also asking permission before doing that. Why? Because he has GI or history of gastroenteritis. The cranial nerve, you did examination, but I believe in the exam you cannot do all these steps because the lower limb examination itself, as Dr. Muhammad said, at least 2 minutes, maybe more, because the tone, power, reflex, coordination, sensation, the gait, the Romberg test will take time. At least 2 minutes, maybe more. So at least focus examination, but be sure that you cover the other manifestation or other differential, like Miller Fisher here. It's good differential. So you said I will examine the eye, extraocular movement, and diplopia if you have the history. The heart, I don't think it's important to ask. You can ask about the vitals if you want to say there is autonomic involvement. So you can say any tachycardia or hypotension, particularly the posture hypotension. So you can say this is involved in the vital chart. Be sure that you are asking the vital chart once you go to the patient. It's necessary part in your examination. Whenever you are going to the patient, ask the examiner, how is or how are the vital signs of this patient? He will tell you as outside, he will tell you in the paper, whatever he will mention, but be sure that you ask about this. Why? He might tell you this patient is febrile. So you can conclude there is infection. Good thing here you mentioned. So the physical examination, I can give you good, satisfactory. They identify also satisfactory because you have, you mentioned and you picked up all the lower motor neuron lesion in this scenario. You also remember the reinforcement, which is important whenever you have a reflexia. The clinical judgment, I will add only to your approach, or not. I will add. I will focus on this part which you already done. And it's very important. They fail some of the candidates in Egypt. I think Cairo Center, they brought this case as a Guillain-Barré, and the doctor didn't mention the forced vital capacity and admission to the ICU to monitor breathing, saturation, which you remember, Dr. Ihtisham, which is very good. I will admit the patient from the first decision. Why? Because he has alarming signs. This weakness is ascending. It might involve his respiratory muscle. So the clinical judgment, it could be satisfactory. The differential here, as Dr. Muhammad said, there is missing differential. And I wrote in the chat box one of the diabetic complication, diabetic amyotrophy. I guess it could be there as a differential, Dr. Muhammad. What do you think? So if I said it could be diabetic amyotrophy.
Yes,
Oh,
Dr. Best. Yes, yes. This is one of the complication can be put in the list, but because of the history, there is positive there.
yeah,
So it should start by the positive and the high risk, then the last one, because this
yeah,
last one can controlled by only controlling RBS.
yes.
The other one, if they didn't start the medication, he will be very fatal for the patient. Yes.
Exactly. So again, the occupational here is very important. The lead exposure. So lead poisoning can be even if for the long term, yes, it can present now. Yes, it will be there for the long term as a job, but with the time, the patient will have a limit, and the level of leads will be precipitated, and the manifestation of toxicity will appear. So it will be one day, or it will be over weeks or over days. But the patient already mentioned to you that I have this weakness over the last 2 weeks, which is ascending. Yeah, lower motor neuron or lead poisoning can lead to lower motor neuron lesion. Along with the abdominal pain, you can say also acute intermittent porphyria. So both of them are fitting. Botulism, yes, if he has generalized weakness, floppy, and as this patient is having, even in the eye, dropping of the eyelids, salivation, as Dr. Muhammad mentioned. But if you mention Guillain-Barré and those differential, it's for me, it's fair enough. The last, the concern, yes, you did well regarding the concern. The welfare, here, if I said there was hypoglycemia and you didn't ask about hypoglycemia, which can lead to dangerous manifestation there, so they might minus you. Please, not only the hyperglycemia, it's hyper and hypo. Okay, show the examiner that you are covering the diabetes from all sides, not only the hyper. Whenever you have patient with occupation, don't forget to ask about the question of impact. How is the impact? Although you asked it earlier, I believe you did that, so Dr. Ihtisham, but I'm trying to remind others that whenever you ask about the job, what's your job? Immediately ask how the impact in your job. If he said, yes, I'm affected, you can be sorry immediately on the spot. Yes, I'm so sorry for your suffering. We will help you in this. So in general, you can have some of these facts satisfactory, but minus in the clinical communication, minus in the welfare. Others will be satisfactory, Dr. Ihtisham. Any comment or question, Dr. Ihtisham?
Yeah, thank you very much. I just wanted to ask you that how many differentials
Yeah.
are okay, I mean, or a must rather, not okay, to give in
Okay.
the exam? Yani, if you want
Yeah.
to go through to at least how many differentials you have, should
You
have.
know, I will tell you now. You might give 2 differential or 3 differential, and the examiner will be satisfied. But he will not be satisfied if your differential is not fitting your case, right? So he will tell you what else, what else. You might reach to the number 6. If you mention the differential he want to hear, he will tell you okay. If not, he will ask you what else, until the minute or the seconds for this part of skill will be lost or the time finished. So he will skip to the next skill if he want to help you. But if you mention the differential from the first or second or the third one, he will say, okay, how to investigate this patient.
My
But you know,
comment,
yes, Dr. Muhammad.
uh, uh, regarding the differential, be sure if you give one differential, he will minus you. This is sure. Even you know the diagnosis and it is confirmatory and everything is going with it. Even you give single differential, you should must tell him another differential, at least one or two. Like here, if we مثلا, if we for this case, sometime it is one differential, but subtypes after it. يعني we can say for this big case, ascending paralysis for differential diagnosis. Maybe infectious, maybe HIV seroconversion, maybe chemical lead poisoning, maybe like this. يعني even you have one differential, put under it another differential to be fitted with this differential if you stuck the يعني and you don't know the accurate diagnosis. So at this time he will be happy for you. But if you tell والله straightforward, this is aortic stenosis, this is syncope, this is مش like only one, he will not be happy for you. Yep.
Yes, I agree with this comment. Yes. So please, not only differential means the diagnosis, even the case is straightforward. You have to put something else and to say, but again, is that, sir, I found this and I cannot say this is a case of, but I should roll it out in this way. Even cancer, you can say at the bottom of your differential, but I would like to roll it out because it's something serious. I should think about it in such case. So it's not a matter of number, but at least 3. But if you don't mention, the examiner will be kind if he asks you what else till he reach to the case. You will be lucky if you have such examiner. Some examiner he will ask you what your differential. If you mention one differential, if and then he skipped to the next skill or the next question, and you didn't give him the differential, and he'll be very toxic examiner really to minus you if you didn't mention the diagnosis. So I hope you will find that kind and a good examiner to ask you till even the number, for example, 7 or 6 about the case. If he want to hear it and he want to give you the mark, he will ask you even till the number 8. But I don't think the time will be enough to mention all this differentiation. And if you kept quiet, for example, seconds, like you are mentally blocked or you don't know more about the differential, he will jump to the next question and he will minus you, of course. But at least 3 differential, Dr. Ihtisham, you should mention. Any other question? Sorry. Okay, anyone want to add any question?
Can I have just one comment, Dr. Hisham?
Yes.
I think knowing the differential or the diagnosis from the beginning is a double-edged sword, because you, as Dr. Muhammad, I think, mentioned that that you've been focusing on GPS. So I will not repeat the history that has been mentioned by the others. All the infectious cause and chemical, all this should be mentioned in the history. Even if you reach the diagnosis, you should exclude. Asking about, I think in the pulmonary symptoms you ask about cough, but you haven't asked about the shortness of breath, which is the most important. Allergy also, I'm not sure if you ask about this or no, but this should be included in a history. So in any condition, I just remind myself in terms of history taking, I mean in terms of differential. So I remind myself with 3 C's, which is cause, clinical, and complication. So the cause is the risk factor for the disease itself, and the clinical is the clinical manifestation of the disease, and the complication. So there is 2 complication associated with Guillain-Barré, which is autonomic neuropathy and facial palsy. So also you should include questions about these in your history. Okay, if you notice any deviation of your mouth, any problem with closing your eyes, autonomic neuropathy, 2 to 3 questions, and I think he mentioned about some sexual problems. I think it's related to erectile dysfunction, if I'm not wrong, which might be associated with Guillain-Barré as form of autonomic neuropathy. So these questions should be added. In the examination itself, you started with the general, but as a matter of time restriction, and you've been having neurological examination, which is like taking a bulk of time. So always start with the system involved, and then you can just, because you've mentioned fundoscopy even before neurological examination, which should be volunteered, I think, at the end. So start with the system involved. If there is one cranial nerve that you should examine and you should start with should be the facial nerve. Yeah, I think that's all. Thanks.
Perfect. Thank you, Dr. Ahad. Actually, this is what I like from all of you. Even while commenting, you are focusing on this part, it will be applied to yourself. So please, when anyone has any comment, do it, even you are not the participant. It's open for all of you. So Dr. Ahad give us some of the clues, what to do, what not to do. She will do so whenever she has a case or she want to practice in any day. This is the advice I want to give to all of you, not only to write in the chat box. This meeting is free and free for everyone to mention or to comment about everything or anything. It's even to ask. Give yourself the time to have the confidence from talking in front of others. In the exam, believe me, you will be mentally blocked. You will have a lot of stress. You will forget everything. The examiner just one point or one side to you. Whenever he will look at you, maybe you will forget everything. How to gain this confidence? By talking. Talk and give some information, some instruction, some advices. I'm not a mentor to say only me to advise here. No, everyone can advise from his point of view. Maybe your specialty much better than me in this part, and you have a lot of information. Not only that, even if you practice this case recently, you might have some information I don't know about. So this is the way how to gain more confidence to be ready for the exam, not for the next diet, maybe the diet next after the next coming diet. Again, thank you, Dr. Ahad. Anyone has other comment or question, please let me know before ending the session. There is new basis center in Jeddah, likely to start in second diet. Yes, I heard this news, Dr. Hisham, which is very good news. Actually, we wish for that, and we send them. By the way, this group that announced for that, we sent to the RCP people earlier. Maybe this is the reaction, and you don't know also is it real or just rumors. So we wait for that, but it will be good, very good for all the candidates in Saudi Arabia. I think in Saudi Arabia, and a lot of candidates, maybe much more than the in Gulf all. But it's okay. It would be good opportunity for those candidates in Saudi Arabia, and hopefully the one who couldn't have a diet or a seat in this diet, next diet, if Jeddah will be opened, apply in Jeddah. It will be much better because you will be comfortable more not to travel outside Saudi Arabia. I'm talking about candidate in Saudi Arabia, which is a very large number. Thank you, Dr. Hisham and Dr. Muhammad. Anyone else you want to comment before ending the session? Satisfied all? So see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Walaikum assalam.